Hey, everybody. Welcome to this episode of the Future of Medicine podcast. I am your host, Dr. Aaron Wenzel, and I'm, as always, joined by the lovely and talented Jen Justice.
Hey, Doc. Good to see you.
Good to see you. We are excited about this episode. This is about the C word, one of the most scary topics in all of health, probably next to heart disease and Alzheimer's. Cancer is certainly in the top three most concerning conditions for anybody who's ambitious for a long, vibrant life. This episode is about cancer screening, the old way versus the new way, kind of a play on the last series we did on cardiovascular disease, the old way versus the new way. We just enjoyed presenting it that way so much that it made sense to do it again.
Yeah.
And something equally as important. We've got several sections in this content, and we're going to start in this first section, Jen, with just defining the significance from a historical perspective. Where are we with cancer screening, and how did we get there? Cancer is the number 2 killer of human beings.
Ugh.
Heart disease is number 1.
Mm-hmm.
Cancer is number 2. And I would just say that it's confusing, it's complicated, mostly because it's super scary, and it's hard to find consistent recommendations, screenings, treatment. Tends to be expensive and variable based on the market and resources that your community has. Why don't you help us and help the listener kind of catch up with where we are with cancer screenings, and how did we get here?
Sure. Well, thanks for that intro. As you and I were prepping for this, I think there's probably not a human on the planet that doesn't know somebody that has had cancer or hopefully overcome it. So screening for cancer is super important. You want to try to catch it early so that it doesn't spread. And historically, these cancer screening tests have been population health based. And what I mean by that is basically they look at the entire population and they look at, well, when did cancer become evident? At what age? What screening test can we reliably do to try to catch it early? In a lot of these cancers, the most popular one probably for a female being breast cancer, we have mammograms. Mm-hmm. For men with prostate cancers, we have blood tests, and then we can move to imaging if we need to. So imaging tests, blood tests. For some, like colorectal cancer, you have to go see a gastroenterologist and get a colonoscopy. So it's all over the board, and it's not individualized. As healthcare providers, when we meet with our members, we do a deep dive into their family history. We want to marry that with if you've had a grandparent with cancer, what kind? When did it happen? If you have a parent with cancer, what kind? Mm-hmm. When did it start? What treatment did they go through? If they did detect anything. But, we're kind of limited in the options that we can present people right now based on imaging, blood tests, those type of screening tests.
Well, yeah, especially since these standards are what insurance companies and third payers tend to base their decision to pay or not pay on.
Yeah.
And interestingly, this isn't any different than you and I in our practice of medicine. It isn't any different than the way we handle heart disease or performance or weight loss. We don't do population health.
Yeah.
We do health of one. Mm-hmm. And ironically, no healthcare provider actually does population health.
Right.
People who write recommendations do it based on population health. But if you're a practitioner of health and you have another human across from you, that's one-on-one. Mm-hmm. And if you don't have any capacity to augment your strategy based on the actual human sitting across from you, it's better than nothing.
Yeah.
Right? Which is the definition of population health. If you were going to hang a shingle in the middle of West Virginia where there's no resources, here is the bare minimum. Rather than recommend, they should call it the bare minimum.
Yeah. Yeah.
This is the minimal viable product to call yourself a health provider.
Well, and the other important point is that for like when we were researching out for this podcast, lung cancer is the number one cancer
Killer.
number one cancer killer
Mm-hmm.
of humans, which shocked me because we always hear about breast cancer in women or cervical cancer or, prostate cancer in men, but we don't have a great screening test for lung cancer. We don't have a great screening test for pancreatic cancer or ovarian cancer.
right.
I personally have a friend, she was a dietitian, ate super clean, worked out all the time, had a very strong history of cancer in her family, ended up with ovarian. By the time they found it, it was stage
It's too
4.
late.
And so with these deadliest cancers, and she's a perfect example, because we don't have great screening tests, by the time you do find them, it can be too late.
Right.
So, and that's another downside to the whole historical,
Yeah.
the way we
No, I mean,
we
and
have
I think
tested for it.
I think the main take home point of this first section is we have for the cancers that we have screening tests for, I think we do a really good job. Assuming you're getting these screenings. So
Right.
cervical, breast, prostate, colon. Do the basic. I
Yeah.
mean, absolutely. If you're not at least doing that, let's start there. But I think as a teaser for later in this episode, we're going to talk about something that we really both feel deeply passionate that needs more attention and conversation around because people have options. There have been some emerging breakthrough technologies that we're going to talk about in a little bit that should be considered as we march forward in terms of cancer screening and early identification, because speed is the game. Early detection is the game.
Yeah.
Nobody wants to find ovarian cancer.
Right.
But if you're going to find it, let's find stage 1 where you live to talk about it.
Yeah.
All right. So the next section we're going to talk about is really the old way. We're going to dig deeper into the state of the union and what we have, and we've talked about the importance of doing it, but really dig deeper into the unique challenges of our current protocols, recommendations, which we believe are rooted in this old historic way we've managed it, which we are debating may not be the most optimal way. Likely not the most optimal way. So why don't you take it away from here?
So, we talked about the way that we screen, but what's very confusing, especially as a healthcare provider, is that there are standards and recommendations that we are presented with from different unified bodies, right? So, U.S. Preventative Task Force, American Cancer Society,
CDC.
CDC. Yeah, so all these organizations.
The American College of fill in the blank.
Right. So, and those are just the U.S.-based ones. I mean, there's ones in Europe. They have their own screening guidelines.
Oh, yeah.
So, not only do we have discrepancies between the societies within the U.S., but then you bring in other countries as well. Internationally, right. And so what can be hard is, I pulled off from just for breast cancer screening, there are 4 different organizations on this sheet, and every recommendation for mammography is different. Some start before age 50, but that has to be decided by the patient. I'm sorry, what? So I have to tell my healthcare provider when I want a mammogram.
And by the way, does anybody tell the insurance? So that's
Right.
wonderful.
Yeah.
But what if your Blue Cross Blue Shield decides that you don't need it?
Yeah. And then and the duration between screening is different. So some organizations say every 2 years, some say every year. Some say, do it annually for women over 40 years. Some say we need to start at 50. So, if you're in that age group before age 40 and you have a super strong history of breast cancer, you better be getting a mammogram, even if insurance doesn't pay for it.
Yes.
Because you could find something. So, just a rant on my behalf of, and then self-breast exams. I was always taught in school, teach your women to do self-breast exams. All of these organizations say it's either optional or shouldn't be taught. If I find something suspect, I probably want to check that out.
As an aside, my wife is alive twice.
Yes.
from her self-examination. She found both the primary and the recurrence on self-exam.
Yeah.
And by the way, she's had it twice, survived. She's not 40.
Right. And she had the most aggressive form.
She'd be dead.
She would be dead.
Somewhere between a year or two delay in her cancer, and she probably would already not be with us.
Yeah.
It's staggering to me that on average, just continuing this rant on breast cancer because it hits home.
Yeah.
There are so many women who are suffering from this, and yet on average, the recommendation is don't do it under 40.
Right.
Meanwhile, all around me, and I know this is anecdotal and my eyes are on it, so I'm biased towards seeing it, but I'm seeing women in their mid-30s having horrible outcomes.
Yeah.
And families now that don't have a mom before the age of 40. I mean, we have got to look at this closer.
Right.
Yeah, for the sake of moving this conversation along and not just making this about breast cancer, but breast cancer is the most common cancer in women. This is a major, major deal. And when the most common cancer in 50% of the population, women, the recommendations are this confusing.
Conflicting.
What in the world are we doing?
Yeah.
Anyhow, I think it's important to, thank goodness we have mammograms. Thank goodness we have ultrasounds. Thank goodness we have Pap smears, and we have colon. We have tools to capture early screening and early detection for some cancers. But you and I were both stunned as we began to dig into this that 7 out of 10 cancers do not have screening. We don't have the capacity to screen for these cancers. From the CDC in 2020, we already talked about lung cancer being the most deadly cancer of all. 23% of all cancer deaths come from lung cancer. Now, some people can get a screening CAT scan, but very few people are utilizing it, and it certainly is not being mainstream pushed, encouraged. Listen, lung cancer has... So colon cancer is the number 2 cancer killer behind lung. There are 2.5 times more deaths every year from lung cancer than there are colon cancer. And thank goodness we have colonoscopy. It does a great job. Recommendations now have moved it up to 45. I'm very proud of that process.
Yeah.
I always felt like 50 was a little late. But 2.5 times the number 2 killer is the number 1 killer, where we don't have any regular standardized early screening, early detection. Lung cancer is a killer.
And you're probably only going to grab that CAT scan on a former smoker.
Heavy smoker.
People die from lung cancer that do not smoke.
Yes. Pancreatic cancer. 8% of all cancer deaths are pancreatic cancer. 0 screening.
Yeah.
Ovarian cancer. 5%. Sorry, not ovarian. Liver cancer. 5% of all cancer deaths are liver and biliary tract cancers. 0 screening. Ovarian, I'm not sure what the percentages are, but it's horribly high mortality rates. The point is that 7 out of 10 cancers that people die from, we don't have any screening tests. We are a reactionary system, a sick care system that only responds once someone has symptoms. Well, let me tell you, if you have symptoms as a consequence of a cancer, it's not going to be good.
Yeah, it's already too late.
It's likely too late, which is a sad tale, which is no wonder we're so terrified of this thing.
Yeah.
I just went to the doctor last year. They said everything was fine. 6 months later, they say I've got 6 months to live because there's cancer. That cancer didn't just show up. We have got to do better.
Yeah.
Let's see. Jen, just as we wrap up this section, talk about the regular screenings that we do have in place, even if you wanted to spend a little more time on breast, some of those things.
Sure. For women, really important to get your mammograms. Again, the guidelines say start at age 40, but if you have a strong family history, I would definitely start that
10 years
10
prior.
years prior.
From the earliest diagnosis.
mhm.
Absolutely.
Yep. And even if insurance doesn't pay for it,
Pay
strongly
for
consider
it.
doing that. Yeah. I've talked to many women that are terrified of mammograms. It's nothing to be terrified of. And if you have a great technician, they'll walk you through your very first one, and you'll be smooth sailing after that. They have great imaging technology now with 3D mammograms. That's the only one I get now, which can show much more detail of the breast
That's right.
tissue. So be asking for that. Cervical cancer, again, your pap smear, get that from your,
With reflex HPV.
yep.
So
with
talk to your OBGYN or your family doc, whoever's doing these annual exams for you.
Yep. Prostate cancer for men, again, you touched on it, an annual PSA, which is a blood test. And then if the level is above a 4, is that what we go by now?
Yeah, well, according to Population Health,
Yeah.
it can't be prostate cancer unless your PSA is over 4, which is garbage. But nonetheless, it's going to be hard to do anything beyond getting a PSA unless it's over 4. We have found dozens and dozens and dozens and dozens of early prostate
We
cancers.
have.
Well below a PSA of 4. But that is the recommendation. But at minimum, guys over 50, absolutely. I would encourage anybody over 40, and same thing with breast. So prostate to men is like breast to women. I mean, it is the most common cancer in men. If you have a positive family history of prostate cancer, it tends to really run strong in families. I mean, if there's a strong family history of guys in your family having prostate cancer, 10 years prior to the earliest guy you can find that got diagnosed. So if somebody got diagnosed at 46, at 36, you better be getting annual PSAs and watching that like a hawk for any variation, the rate of rise.
Yeah. Yeah.
How quickly is it rising? Not necessarily how high is it. And this isn't about prostate cancer, but that is a subtlety. But you're not going to see that data unless you're tracking it.
Right.
And then colon, right? We've talked about colon.
Colonoscopies.
Men and women. 45 now.
Yeah, 45. Yep. I'm behind.
Or 10 years. Me too. By 2 years.
I know.
It's hard to march out. Like this just changed a couple years ago. It was 50 forever. My father had an upper GI cancer. And it has been highly on my radar to do before the recommendation. I thought I was doing really good because I was going to do it by like 45. And then the recommendation became 45. And then COVID happened, and we've kind of blinked, and 2 years have gone by, and so whatever. But yeah.
You do bring up a good point about the pandemic. There's plenty of people that have delayed or
oh my gosh.
Couldn't get in for their screening tests. Make
We're
sure
over
you
2 years
schedule
out
those.
now
Yeah. Get
of
on the books.
world changing, and people keep waiting for it to go back to normal. Ladies and gentlemen, this is the new normal.
Yeah.
Like whatever has been put off, it's time to do it.
Yeah.
Because your future depends on it in a lot of ways. So just to recap this section, there's 0 screening tests or surveillance protocols, no standard of care for massive killers like lung, pancreatic, ovarian. We've got to do better. In this last section, we're going to talk about the new way to be thinking about cancer screening moving forward. And we've already talked about kind of the way we are now. And I think at a bare minimum, we need to do whatever the recommendations are, albeit they are vulnerable to miss people because they are based on population health, which we've talked about. There is a very exciting technology that has come online in the last maybe 18 months that we want to present to the listener so that you can think about this and potentially have conversations with your physician to see if this makes sense for you to overlay on top of the current population-based recommendations. Jen, tell us about the Galleri test.
So this is so exciting. You and I have both done it.
Yes. It is scary.
I was, during the waiting period,
Sweaty
you're like,
palmed.
oh my goodness. But
Yeah.
Anyway, so Grail is the company, and they have this wonderful test called Galleri, and it's a simple blood test. I've drawn it on several of our patients, our members. 2 vials of blood. Takes about 5 minutes. You don't have to fast, which is amazing. But it tests for 50 plus different cancers, which is amazing.
How's that possible?
Well, our cells actually secrete DNA. into our bloodstream, healthy cells as well as cancer cells. So what this blood test is doing, it's basically a biopsy of your blood, if you will, but it looks for abnormal DNA cells in your bloodstream, specifically cancer cells. And with a high level of accuracy, and it takes probably about 10 days for this whole test to come back, so there's a little bit of a waiting period, but with a high level of accuracy, not only does it detect cancer cells in your blood, but it also points to what we call a signal of origin. So it can basically tell us if a positive test does come back, where is the cancer? So we're not spinning our wheels and wasting time doing some imaging tests that are fruitless because we're just kind of chasing this cancer down. We can pinpoint exactly where it's coming from, which is super exciting.
Yeah, I mean, the fact that these cancer-based DNA particles kick off a particular signal, these algorithms that this company uses to identify these what they call cancer signals, which are particular DNA sequencing, because all cancer behaves very similarly.
Yeah.
And it's these signals, these patterns that the technology is picking up that normal non-cancerous cells don't behave this way, so that would not be a signal. And these cancer signals can then also give you a highly likely tissue of origin to give you some kind of marching orders of start here, like the red X, like start here. I think, what are the benefits, Jen?
Well, as we talk about in a lot of our podcasts,
Like, why would we do that? Like,
we want to be on offense.
Yeah.
You know, we don't want to be defensive when it comes to things that take people off the planet. So if you listen to our heart disease podcast, it's one of my favorites that we just did. It's really rooted in being offensive with everything related to heart disease, and it's no different with cancer. You know, you can't sleep on this, especially if you have a family history.
oh my gosh.
And if this is a new technology, you know, why wouldn't you want to put it in your arsenal, you know, at least to give you peace of mind too. You know, I mean, my mom had breast cancer. I'm not thrilled about the possibility of even remotely that happening to me. So to do the Grail and get a clean blood test was very reassuring.
So does insurance pay for it? How much does it cost? Like, what are the details?
So yeah, the cost is around $1,000. Probably varies depending on the provider. Insurance doesn't cover it right now,
Right.
so this would be an out-of-pocket expense. But again, as we've talked about some of the
It's a lot of data for $1,000.
Yeah,
Especially if you're the right risk profile.
Yeah. And you know, the other thing is the accuracy of it. They've designed it to be what we call specific and sensitive. When we talk about a lot of these tests, whether it's a strep test here in the office or a Grail Gallery test, you want it to be as sensitive and specific as possible, and you can kind of talk about that as well. And it's simple. I mean, you don't have to fast. You just
I
pop
love
in
that
for
the
a blood
most.
test. We send it off to the lab. They analyze it. And, you know, I was kind of expecting more of a, yay, you don't have cancer, but it just comes back and says not detected. So
Matter of fact,
it's kind of underwhelming.
No cancer signal detected.
No cancer signal detected. So great. Moving on.
Yeah. Yeah, I mean, and I think those are clearly the advantages. I want to talk a little bit about some of the limitations,
Yeah.
potentially disadvantages, some things to consider, which is why it's not like everybody should run out and do this. Look, it's a test, and all tests have inherent imperfections, which is why it's very important to pursue tests that give the most upside with the least amount of downside. Look, I mean, I don't think $1,000 is too much to gain this kind of information for anyone who has the right risk or concern. But $1,000 for some people might be cost prohibitive.
Yeah.
So there is, I would say, a limitation to this is there is an investment, and there's no sign of insurance paying for this in the near future. You would hope that as this becomes more widely accepted, the data becomes even stronger and stronger, and the market pressures are what they are, that insurance companies would begin to adopt this into their preventative you and I don't deal in the world of insurance, which
Right.
is such a blessing,
Yeah.
but like you would hope that eventually that would happen. But right now that is not the case. This is going to be an individual's investment. I think that's a limitation, something to consider.
Yep.
I think really before doing this, the number one thing I feel, and the one thing I really stress with all of my individual patients before we do this, is there's a real downside, and that is there is a 1 in 200 risk for a false positive.
Mm-hmm.
Well, what does that mean? That means you take the test, it says you have a cancer signal, but you don't have cancer. Well, that would be a stressful thing.
It would be.
And I be honest, I really push their data team, their scientists, to help me understand what a positive means. And I spent a few weeks really thinking about this, and ultimately I came down to, I don't love the fact that 1 in 200 people who get this test are going to get a positive and ultimately not have a cancer. And we're going to go through all of this, all of the pain and the suffering and the stress and the fear, but nothing is going to come up. On the other side, out of those 200 people, there's 199 people who didn't know they had cancer, but now they do.
Yeah.
Which is a pretty compelling position.
Mm-hmm.
And I think that as long as you go into this knowing that there is a 1 in 200 chance that you might have a positive, and we may not be able to find anything, it could mean one of three things, or maybe more. I can only think of three. One is that it's just wrong.
Yeah.
Just a limitation of the technology to not be perfect, because perfection is an illusion anyway. It could be that it's so friggin' accurate that it's finding it less than a millimeter or 1.5 millimeters in size of a tumor, where standard imaging, even MRI, because I think MRI can only get down to about 1 millimeter.
Mm-hmm.
So it may be super duper early. And what was the third? I've spaced on what the other third thing. Oh, the third might be to be determined, which I think Grail has done a great job and come in and help me if I'm misstating, but my understanding of their position on this currently as of summer of 22, that if you get a false positive, they will pay for subsequent repeat testing at no cost.
That is correct.
Which I thought was a very honorable thing to do to stand by their technology.
Yeah. So not only, I mean, they have a protocol that we can follow,
I think the last vulnerability that I can think of that's worth sharing is there is no recommendation currently on how often to do it.
Mm-hmm. Yeah.
The answer is I have no idea.
Yeah.
Practically speaking, I'm marching this out one by one by one by one. Who is the person?
Mm-hmm.
What is the family history? What is the risk profile? What are their behaviors? How concerned are we? If it's just we want to touch and see, maybe it's every 3 to 5 years. If it's somebody with a super strong family history, my wife, we're going to do it annually.
Yeah.
Until further notice.
Yep.
Along with other surveillance, we're doing ultrasounds, we're doing other things. But I think how often you do it needs to be a discussion with your provider as well.
Yeah.
Not just should I do it.
Right.
I think the bottom line is this, Jen, and I think we can wrap this up and put a bow on this episode by just saying cancer is a massive deal and everyone knows it.
Mm-hmm.
I'm glad that we put a little bit of data and number around this to really anchor. This is a major thing. Number 2 killer of humans, and 7 out of 10 of this killer don't have screening tests.
So you must take an offensive
You have to go
mindset.
on offense, or you
to.
are playing with a statistical roulette.
Yeah.
That you will get it and you will catch it late and you will have a bad outcome.
Mm-hmm.
If you go on defense here, you're playing with when I catch it, if I catch it, it will be late.
Yeah.
And I can't rest with that.
No.
As much as I don't ever want to find it,
Yeah.
if I have to march through cancer personally or with my members, I want to do it early, so we have time, because speed is everything.
Yeah.
So it's a big deal, number 1. Number 2, don't stop doing all of this. It's not that they're bad. It's just that they're incomplete.
Yeah.
Do all the standard recommendations of screening. And if you have a unique story, if there's an element of your story that makes you want to do it early, try to build a case for that so that insurance can pay for it. If not, find a way to get that screening so that you feel comfortable that you're doing all that you can. And another plug for Find Your Team. If you feel like you don't have an environment where you can have these conversations, you have to find someone else.
Yeah.
If you're shooed away and poo-pooed and silenced and there's no conversation and my way or the highway, that's likely not a great fit for you.
Yeah.
You need to find that person, whoever it is. And then the last thing is this Galleri blood biopsy cancer screening is on the market. It is available. It deserves some attention. It deserves some conversation if someone listening to this is interested. There are lots of benefits. There are a handful of drawbacks that you need to get your head around before you embark on this journey. But I'm really excited. You know, it's early, right? It's super, super early in this technology, but it's very promising. You and I, thankfully, have not had to walk out a positive test yet.
Right.
It's all been puppy dogs and rainbows so far.
But we will.
But when you hunt, you find things.
That's right.
And so we'll probably create some content at some point in the future once we navigate some of the well, here's how it happens if you but we don't have that yet.
Yeah.
Give us some of your final thoughts on this topic. Just whatever is on your mind right now.
Yeah, if I could leave you with anything, it's don't ignore symptoms. You know, if something doesn't feel right, if you don't feel right, talk to your healthcare provider about it. Be honest about your family history.
Yes.
Dig into that. Ask your parents, ask your grandparents if they're still alive. Know that, I wish my grandparents were still alive to kind of dig into that a little bit more. Hopefully your parents know about their family history, but it is important, and it's important to share with your healthcare provider. And then if you are behind on your screening tests, or you're kind of wavering on getting them, talk to your healthcare provider about your fears and your apprehensions too, and have them help you walk through that. But don't delay in getting it, because like we said at the beginning, you probably all know somebody that has had to walk through cancer, and it's just not great. So
no, never. It's never great, but it's especially bad when it's late.
Yes. Yeah.
So I hope this was interesting to you, and please share it with whoever you think might find it useful. Let us know what you think, and until we see you next time, take care.